This is your respiratory and other station. Please see the picture and proceed with your examination. Okay.
Okay.
This is a 5-year-old child. Imagine his 5-year-old child. Okay.
Okay. Okay. 5 years.
I'll give you time now, 4 minutes from now.
Okay. What's the patient name? 5-year-old?
Kamal.
Kamal. Okay. Okay.
I will keep.
Okay, please. When we start the time.
Yes. Yes.
So, Dr. Sridev, you want to start? If you want to start, start. Hello?
Okay. Yes, yes. So first I will introduce myself and take permission from the mother, do hand hygiene and go to Kamal. And I will make rapport with him. So whether he is communicating with me normally.
Yes, well communicating.
Okay, then I will check if he has any dysmorphic features over the face or anywhere in the limbs. And also
No
I would like
unusual,
to check.
no unusual
Okay.
features. Okay.
Okay, whether he is in distress, whether well looking or
Not in distress. I can say mild distress. Okay, mild distress.
okay. Any special surrounding like on monitor, any IV cannula or any
No.
sputum pot, any like
Yeah,
nebulizer?
you can see a sputum pot only.
Okay, anything in that like cough color or anything?
No.
Okay, then I would like to check first the respiration rate as child is in distress. What is the rate?
RR is 30.
Okay, then I would like to proceed. What about the weight and height?
He is short for age, but not very short.
Okay, then I will start from the hand examination. I will look for the clubbing by putting both the index finger together, and I will check any pallor, any jaundice in the hand.
No pallor.
Okay, any scar mark or any deformities in the hand?
No scar marks.
Okay, no clubbing also.
No, clubbing is like it's improving like that. I mean, it's
okay. So there is Okay. Then I will check the pulse, whether it is palpable and normal.
Yeah, pulse.
And what is the rate?
Normal, 80 beats per minute, regular.
Okay. Okay. So blood pressure I will check at the end. Then I will go to the face to look for any pallor and jaundice in the eyes.
No pallor, no jaundice.
Then in the mouth, I would like to check if any highest palate, any dental, how is the dental hygiene, any cyanosis?
No cyanosis, and it's fine. Mouth is fine. Okay.
Okay, then I would like to inspect from the neck and the chest together to look for any swelling or I can see like any potaka at any central line or any scar mark over the neck or upper chest. And in the chest, I will check for any asymmetry, any any chest wall deformities.
No chest wall deformities. And
okay.
What else you want to check?
Any visible pulsation, any scar mark? I can see right thoracotomy scar, and below that there are two small scars. Anything in the front also I would like to
No,
check. Any
front
scar mark?
nothing. Front nothing. This is the only scar you can see.
Okay. Then I would like to proceed with the respiratory examination. Also, I would see any chest retraction, supraspinal retraction, intercostal retraction. Anything is there?
Yes, but it is very mild. It is maintaining the saturation well.
Okay. Then I will check for the chest expansion. So
Okay.
whether it is moving equally on
No, on the right side it is
both
less.
sides?
Right side it is less.
Right, less. Okay. Then I will check for the apex. I will put both the hand on the chest, right and left, and I will see where the maximal like pulsation I am feeling. I will check there. So where is the apex?
The apex is medial to mid clavicular line on left side in fourth intercostal space.
Fourth intercostal, medial to mid clavicular line. Okay. Okay. Then I will check the position of the trachea. So whether it is central or deviated.
Deviated to right side.
Deviated to the right side. Okay. Then I would like to do the percussion. Percussion, I will start from the above clavicle, on the clavicle, and below that till I get the dullness. So how is it? Whether it is resonant, hyperresonant, or dull?
It is resonant. It is resonant on both the sides, but you feel some difference. Means it is not equal. In some of the areas on right side, you could not
So
feel
there is some dullness.
Yeah.
Okay. Okay. And what about an axillary area? Both bilaterally, when I do percussion, anything I can feel?
No, axillary area.
Finding? Same. Oh, normal.
Yeah.
Okay. Then I would like to, after that, I will do the auscultation by doing the vocal fremitus also. Vocal resonance also I want to do. So I will tell him to tell 99, I will check. So any difference I can see on auscultation?
Okay, you're asking him to tell 99 and auscultating.
Auscultating, yeah.
Yes, it is same in both the area. It is same in both the areas, but in the right lower side, you hear less.
Okay, then I will auscultate for the breath sound, whether it is vesicular, bronchial breath sound, any wheezing, any rhonchi, any crepitations. And also, yeah,
No rhonchi, mild crepitations you can hear in the right lower side.
Okay, I would also like to auscultate the heart to look for any murmur. And also the second heart sound if it is loud.
Time's up, 6 minutes gone.
Okay. So nothing in the heart. You can continue. You can complete your examination.
Okay, to complete my examination, I would like to check the back also to look for any scar mark which I can see inspected. Then I will do the same examination, palpation, percussion, and auscultation to compare both right and left side on the back. Along with that, I would like to also examine the complete ENT examination, lymphadenopathy to look for, and also in abdomen, I would like to see if any gastrostomy tube or any scar mark, and any pedal edema, and blood pressure to be checked.
Okay, so you said.
So today I examined.
Okay, go ahead. Okay, go ahead.
So today I examined Kamal. He's 5-year-old boy who looks short for his age, but weight looks normal. And he has, there is clubbing in the hand, and in the face there is nothing. It is normal. I can see in the chest there is a, there is a right thoracostomy scar, and also there is small scars, 2 scars below that. Along with that, I found that there is respiration rate of 30 per minute with some mild retraction or with mild respiratory distress. And when comparing to the left side, right side, there is reduced movement, dullness, and also there is reduced breath sound on the right side. And also there is deviation of the mediastinum in the form of like the trachea is deviated to the right side.
Okay, give your different.
So with these findings, with these findings of some reduced movement and all these thoracostomy scar, my possibility is most probably this child has undergone some surgery Either it could be lobectomy, most probably lobectomy, or other differentials. For a lobectomy, I will keep different.
Okay. This is right-sided lobectomy. So what are your differentials?
Differential be any congenital malformation, underlying bronchiectasis, and also other possibilities like DT shunt surgery because of the right thoracotomy and tracheoesophageal fistula surgery. These
Okay.
are
If
other.
this was lobectomy, tell me the causes
Yeah.
for lobectomy. What are
Yeah,
the
lobectomy like congenital malformation like congenital adenomyotic malformations or any lobar emphysema, or it could be because of the some local bronchiectasis causing like lung abscess not resolving. So it could be because of like cystic fibrosis or recurrent like
Can you tell some of the causes for bronchiectasis?
Yeah, cystic fibrosis, immunodeficiencies, alpha-1 antitrypsin deficiencies, and
3 minutes up.
tuberculosis. Yeah.
Okay, no problem. For discussion, we can continue because we have to revise. Okay. So tell me, what are the causes for bronchiectasis? You said.
Yeah, like cystic fibrosis,
Okay.
primary ciliary dyskinesia, alpha-1 antitrypsin deficiency, immunodeficiency causing recurrent infections, or any foreign body causing recurrent infection, or because of the malformation, congenital malformations causing recurrent infections, or could be because of the TB, tuberculosis also can cause bronchiectasis.
Okay, I want to know about cough swab. Can you tell me how the cough swab is taken?
Okay, if the child has productive cough and he can take it out, then we can collect that. Otherwise, have to give like early morning gastric aspirate can be taken 3 days continuously. In that also something not coming, that minimal normal saline they give and they take the wash.
Okay.
Other ways like bronchoalveolar levels. These are the other ways to take.
Okay. How do you manage the patient if this was a bronchiectasis case? Before lobectomy, what was the management usually?
Okay.
Medical management of bronchiectasis.
Bronchiectasis management is to give, depending on the culture report, the antibiotics should be continued. Also, the nebulization should be regular for these patients with the mucolytics and antibiotic also. Then physiotherapy is very, very important. Exercise, respiratory exercises are important. Then what else? Then an immunization, vaccination should be completed. And also associated if any problem, that we have to take care of that.
Okay. Do they need antibiotic prophylaxis as well?
Yeah, they need antibiotic. Like according to the culture report, we have to give antibiotic prophylaxis.
I mean antibiotic prophylaxis, both treatment and prophylaxis.
Treatment and prophylaxis, yes.
Okay. So you have to add some more things in order to complete my examination. Can you think over?
Yeah, in order to complete, to plot the weight and height in the growth chart.
Okay.
Then, then
so
also.
What you have told, I will tell you first. You told back because you did not have time to do the back examination, right? So you said back respiratory examination. Then you said ENT lymph nodes. Then you said in the tummy you want to check for gastrostomy tube. Then I have written skin. What you told in the skin, I don't know.
Scar, any scar in the abdomen.
Okay, scar, gastrostomy tube and scar. And you told blood pressure. But apart from that, more important than these things.
Yeah, with this spirometry we can do.
Yeah,
spirometry. Yeah.
Spirometry.
Sputum pot, like no, for that is investigation. We can say the cultures.
No, spirometry, and also you have to tell for the SpO2 chart. You can maintain a chart for SpO2, and also CVS examination. Did you tell CVS examination in order to complete?
Complete. I don't know. I just auscultated and there is no murmur, so I didn't say.
But
I palpated
the complete CVS examination.
Yes, yes.
Because the differentials for this car other than lobectomy is all goes with CVS also, right? Modified BD shunt and
Yes, yes, yes.
so, okay. I think it was okay. But you have to, I think you should be fast and time management. Ask multiple questions at once rather than asking one. I think you have to do like that for the time management. Because you know, respiratory also is little more things to ask in examination. Like ocal, that too, leaving ocal fremitus also, you just did ocal resonance. I think one thing is enough. And preferred is resonance than fremitus, right?
Yes, yes.
Yeah, so despite of that, there was problem in time. I think you can ask 3-4 questions at once to get the answer. This is the only solution. Like, is the child well communicating, well looking, not in distress? What about the height, weight? Like these 3 questions. Then anything in the surroundings, any attached to the devices, any unusual features in the face, like this. So that you will finish a set of questions at once. Make the questions like said. This is my suggestion. I don't know if anyone wants to tell anything, go ahead.
Dr. Noor, Dr. Sridevi, are you going for exam?
Yes, yes.
Did you have listened for webinar?
Yeah.
They have said clearly that you cannot ask any question while you are performing.
Then
Means?
Yes, you cannot
Just
ask
have to
any question.
explain the progress. That's why we're telling is to Dr. Amit also just have to keep on explaining the this I will do this, I will do this.
You will start like this after greeting my after greet to the patient and the parent. I will take the permission. Then I will look in the surrounding. I am looking for. So you will tell like I am looking for any sputum part is there, any oxygen cylinder is there. I will look for the child journal look if there is any unusual feature is there. I will look for the journal build of the child in form of height, weight, and head circumference. I will look for any what else devices is finished. Then I will start my examination from the hand. So just take 1 second pause. Don't ask, is there anything? No, you will not ask. You are not allowed to ask. You will say that and will start from the hand. I'm looking for the child for the clubbing, for the cyanosis, or any
When will the examiner give us the cues that clubbing is present or not?
when you will take 1 second pause, they will tell you, yes, doctor, there is clubbing or there is cyanosis. So I will now go to the check for pulse. I will count the pulse for both
You
hands.
need to say like, after every second, you don't have to ask a question. Just
Even 1 second, not every second. Even 1 second you cannot ask. Even in the whole exam you cannot ask any question. They
so
clearly
you
said.
no.
They
So like
clearly,
for the during the
1
whole
minute, I will mute all. Please, one of you open your mic who is speaking.
I have attended this webinar by myself. I'm not telling by anyone has told me. I have attended this webinar by myself. They said that you will not ask any question. You just imagine you are
Dr. Rohil, the thing is that there are universal cues which you get in the start, like a picture or a video, okay, and then you start your verbalization. But in the middle, sometimes the examiner has to tell you the verbal cues, isn't it?
he will tell by himself, but you will not ask. You will not say, is there anything?
Yeah, you will behave like as if you are examining the patient and you will keep on telling what you want to do. And he will, let's do with Muzna now. The same case before discussion I want to do with the Muzna. Because I want to give her also practice. Let's see how does she follows the rules or not. Okay.
Yeah, that should not be asked any question. You will complete your examination by doing your description. Is where will be the finding? He will tell by himself. He will interrupt you and he will tell, yes, doctor, there is hyperresonant and there is sound
Okay,
is
got it. Now I understand. Thank you.
Okay. Dr. Muzna, let's start.
Yeah, please task.
Okay.
Task.
So
What's
the task is this is 5 years old Kamal. Okay. This is your respiratory station. Look at the picture and proceed with your examination.
Okay. Okay.
I will give you some time when you're ready.
No. I have prepared my template. Just when the discussion was started, I had joined. So I had prepared the template at that time. So I'll
Okay,
start.
if you want to start, you can start. No problem. Dr. Anamika, you can keep the time again.
Yes, yes.
Okay, 6 minutes and 3 minutes. Okay, start.
I'll wash my hands and introduce myself. This is Dr. Muzna, and I'll take permission from Skewed Kamal. Please, can I examine you? Then I will expose him to the extent that he is comfortable with. I will see whether he is well or he is in distress. I will see whether he is grown well for his age or height and plot his growth on his centile charts. I will look in the surroundings for any supporting aids, any sputum pot, any medications, any nebulization, anything that will give me a diagnostic clue. I will look at Kamal's face to see.
Let me give you. He's short for age. There is a sputum pot. Okay. The mild distress is there. RR is 30. Okay, go ahead.
Okay, thank you. So I will look at Kamal to see whether he has any syndromic features that are there. I'll start with his hands and see whether he has any pallor, any clubbing, any cyanosis, any deformities of the hand, any scar marks, any palmar erythema, or any significant finding. I will see for his pulse, for the rate and the rhythm. And I will see for any cyanosis clubbing that is there in the hand. I will scan the
clubbing is there. Clubbing is there, but no cyanosis, and the clubbing is improving. Next.
I would like to see what is the grade of the clubbing by softening of the nail bed or absence of Shamrock signs that is there. I will, or
grade
has it become great? Okay. Then I will scan the entire upper. I will see the pulse rate for the rate and the rhythm of this child. And I will child to try to scan the forearm and the arm to see for any scars, any deformity, any stigmata that are there. No. I would like to check, see the eyes or ears for any vision aid, any hearing aid. Eyes, I would like to pull. I will tell Kamal, please pull your lower eyelid. I would like to see for the pallor, and I would like to see for the jaundice in the eyes. In the nose, I would like to see for any nasal polyps. In the ears, I will see for any hearing aids or any grommet inserted that are there. On the mouth, I would like to see any cleft lip, cleft parade, any central cyanosis, any tonsillar hypertrophy that is there, or any stomatitis or ulcers that are there. Okay. In the neck, I would like to see for any swellings, any scars that are there. At the same time, I would just like to palpate for any lymph nodes. I would like to inspect the chest. As there is respiratory districts and the RR is 30, I will see whether there are any other muscles of respiration that are used, like the subcostal or the intercostal muscles. I would
there
like
is
to stand.
Slight subcostal and intercostal retractions.
Okay. I would stand at the right side and the leg end of the child to see for the shape of the precordium, to see for any scars, any devices, any visible pulsations that are there. As for the universal cue that I have been received, the right side, there is a lateral thoracotomy scar. I would like to see whether it's a healed scar or it's a healed. I would like to see whether it's healed or not. Below the right thoracotomy scar, I can see a lateral scar as well as a circular scar that is there below. Then I would like to ask Kamal whether he has any pain. I'll warm up my hands and start palpating him. And if he has any pain, please stop me. I will first look for the apex impulse, apex beat. I would see the site and the quality of the apex beat.
Yes, apex beat is medial to mid-clavicular line in fourth intercostal space.
I will see whether it's on the right side or the left side to rule out extracardia.
Left side.
I would like to then see for the position of the trachea by keeping my index finger and my little finger on the clavicle end and the middle finger to see for the position of the trachea.
Deviated to right.
Deviated to the right side. Okay. Then I would like to see for the palpation of the lung zones and the upper, middle, and the lower border, whether there is any reduction in movement of the chest on either sides.
Yes, right side there is reduced movement of the chest.
Okay, then I would like to start percussing in the anterior, axillary, and the back areas to see for the note whether it's resonant or dull.
Yes, in the right side, there is some dullness in the lower part of axilla.
Okay, then I'll start auscultating on both the sides to see for the breath sound and any adventitious sound anteriorly, the axillary area as well as the back. And when I'm doing the back, I'll even see whether there is any spinal abnormalities or scars at the back.
Okay, right side reduced breath sounds and also in mostly in the same area where you felt the dullness in the lower part of axilla.
Okay, I will try to Kamal to please. I would like to check the vocal resonance. I'll tell Kamal say 999 on both the areas. I'll auscultate at the same time and see any reduction in the any difference in quality of the vocal resonance.
Yes, again in the same area, you can hear reduced or no vocal resonance.
Decreased vocal resonance. Okay. To complete my examination, I'll plot Kamal on his centile charts. I'll monitor the vitals, especially the temperature, heart rate, respiratory rate, blood pressure, as well as the saturation. I will do the complete ENT examination, lymph node examination, and for abdominal examination to see for inspection any organomegaly or any devices that are there in the abdomen. I will see for the lower limb edema, lymphadenopathy anywhere else in the body, as well as I will auscultate for the heart for any murmurs. So I'm present. I have my finding is this is 5-year-old Kamal, who is a child who is short for his age, who has a sputum clot in his surrounding. He was presently in mild distress with grade 2 clubbing, has an apex beat in the left position, as a deviated
6
trachea.
minutes up. 6
Okay,
minutes up.
Okay, great.
Deviated trachea towards the right, reduced breath sounds on the right, dull note on the right, and reduced vocal resonance on the right side with a lateral thoracotomy scar. So most probably this is a surgical procedure which has been done for a lung issue. This one.
Okay.
Sorry. A lobectomy. Am I audible?
Yeah, yes,
Hello,
yes.
am I
go
audible?
ahead. Yes, go
One
ahead.
second. Lobectomy which has been performed on the right side.
Okay. So give your differential diagnosis.
The lobectomy can be performed for any bronchiectasis segment which has been infected multiple times. Even tuberculosis of severe tuberculosis of the lobe sometimes needs to undergo lobectomy. Congenital cyst adenomatous malformation.
Taking this as the
Okay, so
bronchiectasis, can you tell me the causes of bronchiectasis? Common causes.
bronchiectasis can be because of infection, obstruction, and immunodeficiency. Infections like tuberculosis, pertussis, measles. Obstructions that can be because of cystic fibrosis, thick secretions, primary ciliary dyskineas. There's no motility, and obstruction because of lymph nodes or tumors. Immunodeficiencies can be primary or secondary. Secondary like HIV, primary like hypogammaglobulinemia or hyper IgE syndrome.
Okay. Can you tell me about the cough swab? How they take in children?
Cough swab, the child, if he is big enough, and 5-year-old Kamal can help us to give the cough sputum that is there. Otherwise, if he cannot, then we have to give him a nebulization of hypertonic saline to get it. Otherwise, an NGT to be put in situ at night, and early morning gastric lavage can be taken. Otherwise, yeah.
Okay. Then tell me about your investigations and management for this case.
I will first investigate this child and then take a multidisciplinary team to investigate this child. I will do a complete blood count to see for any anemia, or then I will for any anemia, ESR, CRP to see for any active inflammation that is there. I would like to even do a chest X-ray to see for any new infection that has come up. If he's coughing, then I will take a sputum for culture, a blood culture, if he has any signs of active infection presently. Yeah, and if at all there is any underlying.
Okay, time finished, but we will continue. So apart next
underlying
management.
Then after, if necessary, a higher imaging like a CT scan may be necessary. Management will require a respiratory pediatrician who is going to be the core team leader, who will manage the infections as well as infections by giving antibiotics appropriately. There will be nebulizations, and chest physiotherapy will be required for the physiotherapy that will be required for postural drainage and giving oscillatory exercises of the chest. A chest surgeon, a pediatric surgeon, that will be necessary if any other bronchiectasis, if there is any is necessary for the lobectomy that has been done.
Just
Then
list the MDT for me. List the MDT for me. Then I will ask you the
respiratory physician, the surgeon that will be there. Then if he has any underlying immunodeficiency, then an immunologist that will be required. Or if he's a cystic fibrosis specialist team that will be required. Physiotherapist that will be required. His family should also be actively involved in the multidisciplinary team, and a social worker if he has any chronic disease. So this he will require any the management of his infections, nebulizations that will be there, postural drainage and physiotherapy that will be required. The underlying disease, for example, if there is infection, then like a tuberculosis or a pertussis, the appropriate antibiotic for that. If there is any immunodeficiency disorder, then
tell me about the medications you want to use. Any medications you want to use apart from antibiotics? You told already antibiotics.
Okay, so medications besides antibiotics, nutrition. So basically, nutrition
support. Yes, that is not medication, but medications.
Medications.
Did you tell mucolytics and bronchodilators?
I said nebulizations, but I did not mention them specifically. Okay, no. Mucolytics and bronchodilators. Yeah.
Okay.
If there is underlying
prophylaxis needed for these patients,
antibiotic prophylaxis is not needed if it is a simple bronchiectasis. However, if it is due to some underlying condition like a cystic fibrosis, which is having a colonized infection, then at that point of time, there will be an antibiotic prophylaxis that will be required.
Any extra immunizations they have to take?
Influenza immunizations will be better if they take that annually.
Okay.
And yeah, and just to see that if it is cystic fibrosis, immunodeficiency, so they have to be on steroids at for certain reasons, certain times of varicella immunization. I'll see to it that it is completed, and their antibody titers are serology is positive for their varicella immunization.
I think we are done. Let me ask for feedback from others before I give. Anyone have any points for Dr. Muzna?
Yes, just Dr. Muzna was too fast, and she had the right technique because she's not asking, but was too fast, and do not give the examiner the time to give her the clues. By this, you may miss some points. By the way, they said this in the webinar. Don't go too fast because examiners, by this, when you say multiple things together, then he may give you may give him to. I mean, he may not give you the whole clues. He may go. He may miss. Even they said they may miss the examiners one of the clues and not give it to you because you go through many things together, and you not give him time to say the thing that the dependent clue he have to go to give it to you.
Yeah, she was fast. I do agree.
Actually, a video exam, so they will, it seems, raise their pen, to say that there is any cue. So
yes,
I thought that I'll look at their pen.
I know why you did this.
I think generally Dr. Muzna talks very, very fast. And then you also, apart from being too fast, you give too much information. It's like you're digging a grave for yourself. You're supposed to give a very short, straight answer to the point, but you give too information and then you go like, whereas, and then when there's nothing for you to say, you stop. Try to take short pauses in between. You have a lot of information, mashallah, you're very good. And then you give too much information, you give too much answer, and then you try and take a deep breath when you're talking.
Yeah. I want to also, I do agree with you. But what I want to tell you is, in the template, divide yourself. Like after general, after telling everything about general observation, give a pause. Like, is the child, you'll start with well communicating, right? Is the child well communicating, well looking? What about the height and weight? Any unusual features? Anything in the surroundings? After telling these things, just give a pause, let him give you the answer, and then you can go ahead. What do you say? Let's divide it into parts. Like after general, divide for the hand. Means the complete whatever you want to ask in the in the palm and the pulse, and if you want to see the axilla, everything, complete hand. Then go for the face, then go for the chest. I think it will be better. Any suggestions like this?
Dr. Noor, I don't want to comment on the presentation. I just have a doubt. While doing the examination, can we do the front, axilla and back together? Because normally we don't do proceed like that, right?
No, no, you have to complete the front and you have to go to the back.
Yeah.
I think it was really fast. Like I speak very fast myself, and people tell me that don't speak that fast because sometimes the examiners are old and conventional, and they take time to register what things you say. So it's better to slow down a bit and don't give all the info in one go. Let the examiner have questions for you. I mean, he has 6 questions written for you. If you answer one by one, you get 6 marks. But if you answer one question, he has 4 questions remaining. He is not going to mark you for them, okay?
Yeah. And also when you are,
And one more thing, like both of Musna and the other candidate before, you take a lot of time in starting the examination. Like for example, the screening questions for every system are very specific. Like for respiratory, I mean, after entering, washing, introducing, I would like to know if the child is well or ill. That is it, not more than that. Okay. Does he have any special facial features or syndromic features, especially in the eyes and ears? Okay. Does he have anything in his surroundings like a supporting aid, oxygen cylinder, or a sputum cuff? Okay, that is it. I would like to start my examination by examining his hands. I would like to start my examination by checking for clubbing, cyanosis. Nobody asked about the tremors. You should ask about the tremors because this is a chronic lung disease. He might be on Ventolin nebulizations. So the examiner might have tremors left, okay? This was missed by both, okay? So in the hand, in respiratory, clubbing, cyanosis, tremors, and pulse, okay? And needle marks. You go to the axilla, puberty or not, it's up to you. Okay, then the face for velar and jaundice, nose for polyps, mucosa for central cyanosis. I don't know whether Dr. Musna asked for central cyanosis or not, but
she asked.
First candidate did not ask for central cyanosis. If you want to go for the ears, go ahead. No need to go for the ears. Then I will examine the neck for any visible pulsations, any scar marks, especially for example for CVP lines. Okay, and then I would start my examination of the chest by asking him to take off his shirt. Okay, you cannot expose the child from the start. If he's already exposed, then it's a blessing. And I will inspect the chest. Okay, I would like to count the respiratory rate, and then I would like to inspect for any scar marks, any visible deformities, any visible pulsations, or any lines. Not more than this. Only these 4 things, not more than this. Okay. Or if you want to add to the beauty of the inspection, you can say, I will examine the chest from the side, from the front and the back, only for scar marks, nothing else. Not more than this. These 4 questions are more than enough. Then I will put
Dr. Faiza, sorry, I'm interrupting you. They have said that in the webinar also, if you are not asking, if you are looking for, like you are saying that I am looking for the general inspection for the scar mark from the both side of the foot end of the bed, then I will look for the any deformity. So if you are not asking what kind of deformity you are looking, they will not tell. They clearly said you will have to tell that I am looking for pectus carinatum, excavatum, I'm looking for the
yeah.
So you will have to tell.
Okay,
so that's why this is difficult now. You will have to tell each and everything. Otherwise, they will not tell you. They clearly said that if you will ask, we will tell you. If you will not ask, we will not tell you.
So we
Okay,
should
fine.
ask
Well,
if
I'm
we just
wondering
say
that
any deformity, it's not enough. We have to ask pectus carinatum, pectus
Yeah,
excavatum.
I
what kind
agree
of
with him.
deformity?
He's told, but the thing is, how are we going to complete the
Yeah,
examination
this
by
is the
asking
problem.
for
This is
everything,
this,
verbalizing, talking slowly, pausing? How will
yeah. I
we
don't know
complete?
how can we do this.
I
Yeah,
will
Yeah,
not.
I
I
mean,
cannot complete till
no.
you can,
percussion also with this.
no, no. I mean, you can finish off in 6 minutes. Okay. I have tried it. Respiratory gets finished off. I think so. I mean, just
But
be
see,
very
the thing is, you
specific.
cannot miss out on hearing aids. Okay, in this, you cannot miss out on nasal polyps. You cannot miss out on a cleft lip, cleft palate for a respiratory case. You cannot miss out on the neck also on a respi case. Now, if we are telling every deformity also at the same time to
I don't
complete in,
think it is
and if at the
possible.
same
It's
time they,
possible.
if thank God if they're not telling me that how do you percuss, if I start explaining how to percuss,
No, they will
once
not ask.
I
They will
once
not
I
ask.
just
I
ask
mean, they
about,
will
no,
not
no,
ask.
they can, they ask
They
how
can
will you
ask.
see
They
for the
can ask.
name, or yes, because even tracheostomy they have asked, to have tracheal position, how will you see for the position of the trachea? Now that itself takes
Sometimes
so
they
much
will
of
ask.
time to.
No. Sometimes they will ask, and I don't think so. It's just a competition of to see who will be able to finish off the examination. I think b- because let me tell you, before any examination is conducted, 3 or 4 examiners are supposed to be candidates, and they have to do the examination, and they are scrutinized. If out of 5, if 3 or 4 are able to perform the task in the required time, they will put all these questions up in the station. They will not
Hmm.
literally put up any station if the 3 out of 5 examiners, 3 cannot complete the task. And they
No,
have to
because
examine all
they
those
have to
examiners.
explain everything, because respi is one thing always
No.
is
I think so
difficult to
it is
complete.
possible. It is possible.
Rest, even for that matter, CNS one can complete, but respi is difficult
See, one
No,
thing
amongst all
I
the
want to
six.
tell to both of you is, now I gave you the case, right?
Hmm.
Take this same case and try to practice yourself, keeping the time in the in your phone, and imagine pausing yourself for the examiner's response. Like give a
yeah,
pause and try like that, and
be an examiner yourself and answer to yourself. This is quite right. Yeah.
yeah, and try to summarize yourself in 1 minute. And see, in one day, I think if you try for all the system, like do one case from respiratory, do one case from CVS, from CNS, like this, and try. But recently, when we attended Dr. Salma's meeting, she said everything to explain. Like I will, I will ask for flexion by
Even
asking.
percussion, there was, I heard someone telling, I will put the middle finger in the intercostal space and use the next middle finger to percuss on the right angle, anteriorly, in the maxillary line, and the
How we
posteriorly.
will tell all these things? I don't know. For flexion, we will keep the
Yeah,
hand
Dr.
on the
Noor.
thigh,
Dr.
and for
Noor.
extension, we will keep below the thigh. Adduction, we will keep medially. For this, we will keep laterally. It's very difficult to
Sometimes,
tell.
No, we just have to take
I
seek of
don't know.
flexion extension.
No, I
I
will
mean,
tell you, Dr.
sometimes,
Noor. They have clearly said that examiner can ask you how you are performing this. Like I am saying that I am looking for chest expansion. I would see that is it equal or not. Then examiner can, how will you perform this one? They can ask. Yeah.
Okay, but if he did not ask, I can proceed, right? If I just tell, I
If,
will
yeah,
do chest
this
expansion.
is, yeah, this is no problem. Just you will have to tell what finding you are looking. Like in the chest, I am looking for deformity. What kind of deformity? I am looking for pectus excavatum, pectus carinatum. I am looking for the chest indrawing or this subcostal coastal
Harrison Circus.
Harrison sulci. So I am looking for this scar. So after doing this, I will go for palpation. I will place my both hands on the chest. I will locate for the epic page. I will see if it's on the right side or if it's on the left side, and which intercostal space. He will tell you. So take just a pause, 1 second. He will tell you. So I am going for the pulpit of the trachea. Trachea is in the central or it's deviated. Just you will not say that I will place 2-finger method or 1-finger method or 3-finger method. He will ask
Yeah,
you,
he's
how will
quite
you
right.
perform?
He's quite right. Quite right.
I think so, which I understand. I have attended complete that meeting, but maybe I can be wrong.
No, it's quite right. Like, I mean, they said like try to finish off the exam, and if they want to ask you details, they will ask you, okay, tell me how will you perform this thing. Like, for example, you can say simply in the abdomen, I will start palpating from the right iliac fossa going upward to check for the lower border of the liver. Okay, that is it. But if they say how will you do it, then you can say I will put my tips of the finger or angle of the wrist on the abdomen, synchronizing with the child's breathing, keeping my eyes towards the face of the child to making sure he's not in pain, and I will palpate gently upward. Like this, you have to tell the detail. Otherwise, you can simply say, I will start palpating from the right iliac fossa going upward to check for the lower border of the liver. Then I will palpate from the suprapubic area going up to palpate for the left border of the liver, simply as that. But if you say, how will you do it? Then you have to say these things like pain and respiration like that.
That's what I want to tell. Explaining everything, what you will do, how you will do, we will not be able to complete. So we will just go on taking the exam.
Back
If he
examination
asks,
is
then we will explain.
Like you will say that I would like to see clubbing in the hand, so he can interrupt you. How will you perform this clubbing? So that's how you'll have to tell.
The answer is you will do it by window method. That is it. If he says how will you do it, I mean, if he's literally like going to ask you, then you go for I will like keep my eyes at the level of the nails, or I will put both the fingers. I swear I don't even know how to do it. I just simply say by window method.
Yeah, you will. If he's asking completely, you can say that I will ask the child to put his nails of the both index fingers together, and I will demonstrate him how to do, and I will look for the if there is any window for the shape of sign. Okay, that's you can say like this. But you will not ask anything from the examiner. He will give you any, because they have written there is universal clues, there is dependent clues. So dependent means we are dependent on the examiner. Dependent clues means that. So we are dependent. If we will ask, he will give you. So we are dependent. I understand what I'm saying. If we will not ask, he will not give you. Universal for all. Dependent cues. Dependent cues for all of us. We are dependent on the examiner. If you will ask, he will give you. Otherwise, he will not.
Assalamu alaikum. I hear from one examiner. You hear me? I hear from one examiner last month from one examiner. He told many candidates they are asking during the clinical exam, like, is there is any jaundice during their exam? There is any jaundice, there is any hepatomegaly like this, and he told this is wrong. They should not ask the examiner any question. They should go through the approach. I want to do like I want to. I will observe for general condition. I will check the weight, height, like this. The through approach till you finish. If there is any positive sign or finding in the because they are given from the start in face-to-face exam, they are given some sign from from RCPCH regarding the case. If there is any positive thing, the examiner himself he will tell. He will tell, yeah, there is splenomegaly, and after that you can ask. I want to know about surface texture like this. But you will not ask examiner there is any hepatomegaly, there is any splenomegaly, like I'm hearing every day in the meetings with others. This is wrong.
Hello, Assalamu alaikum. Can you repeat for us this again? What is the best to do? to detect
The best to
hepatomegaly and
do,
splenomegaly.
the best to do, don't ask. Even he told in the last 2 days he write even in the scenario outside, don't ask me any question. And if the candidate for last 2 days in Jeddah, he told, don't ask me any question. He he do like this. He told it is the right thing only to go through approach. I want to do like this. I want to examine for hepatomegaly. If there is any sign, the examiner himself, he will tell, yeah, there is splenomegaly, and you will complete. And only when you are talking, give him chance to answer you. I will do hepatomegaly. I will check for any abdominal distension. Like this, and he will any positive sign, he will tell by himself without asking him.
Okay, thanks.
Welcome.
So when we start the examination, I will check the hand like this, I will tell, or I will tell like I'm looking the hand like this.
Whatever,
Look at
don't
the hand.
ask him a question like.
Okay, just we will explain, and if anything, he will tell. I will just stop.
You will go just you do one thing. What I feel is, imagine yourself that a child is there in front of you and you're doing. Just go on telling what you're doing, like. And now I'm
this is
seeing
the
the hand.
Deva.
Yeah, imagine yourself. So the best thing what I
Yeah.
can suggest to you is,
Okay, so just I'm telling the hand only. I will not go further. So I'm checking I will check the hand. I will look for clubbing by putting the both index finger together. I will check for the pallor, jaundice, any scar mark, any deformities in the hand. That's it. I'll stop there.
yeah, give him some pause in between to give you the findings. If he's not giving, just proceed. If he don't start to speak, just proceed.
But
Don't
without
pause for
pausing,
second.
how he will start? In between, he cannot start and stop and say, right?
That is
We
what
have to give pause.
make your template in such a way that divide it into parts. Like general observation, you will make one part. Then hand examination up to axilla, make one part. Then face and neck, you can make one part. Then you will come to the respiratory. In that inspection, you, after asking all the inspectory findings, pause. Then after asking palpatory findings, pause. Like this. In the template, divide yourself where you want to pause. You got, did you get my point?
Yeah, and he told also, if there is any positive, he will stop you. The examiner will stop you, and he will tell what is a positive.
Yeah, you just go on speaking continuous, but give if you think that after hand I have to pause, maybe he will give some finding, just pause. But if he doesn't start to speak, continue. This is what I feel. Make your template into divisions where you want to pause, and practice those questions to ask continuous. Like well communicating, well looking, what about the weight and height, and anything in the surroundings, any unusual features. For us, ask these 5 questions, and suppose if CNS case as add abnormal movements, also abnormal movements or deformity, depending upon your case, what you ask in general observation, ask completely and pause. Like this, better, right? Anyone wants to comment on this?
Just one comment. On the webinar, as I said, that we have to describe the examination. Like I said, Dr. Musna, I hear Dr. Musna said that like percussion, we do put finger in the intercostal space and percuss. They said like this, even the small features, they said, if you don't ask specifically, I will look, check the eyes for one by one, they said, even on the eye, what you are looking for, on the mouse, what you are looking for. Yeah, I think they will give, if there is a specific feature, may give a picture, but if they don't give a picture, we have to ask in the eyes, in the mouse. You don't say for any dysmorphic feature like this general. If they said even the dysmorphism, you are looking specifically for what dysmorphic feature. They say that we have to be detailed in everything, and we also complain the time will not be enough. They said it will be enough. Just you have to practice this many times, and it will be enough. That's their comments.
Okay, let's now, okay, anyways, practice yourself and let's see how it goes. So now let's go to our case. It was a case of bronchiectasis with lobectomy, post-lobectomy. So let's read for approach to a child with bronchiectasis. So what you will see, you can see the failure to thrive in the child. So the child for age. A child is there, you can see some failure to thrive features like short, underweight, okay, clubbing has to be checked, but why I said improving is since that part of the neck, lobe is removed, he has a resolving clubbing. This is what is my agenda. That's why I was telling that there is clubbing, but it's improving than before. Then you can check for any central line and portacath. If it is present, don't forget these things, or scars for this. If this has been performed before, scars for the portacath and central venous line. Then lateral thoracotomy scar, usually it will be lobectomy, but it is more than exact lateral, it will be near the back, like this scar was given in the exam, what I presented today, the picture, the same scar, it is more towards the back. Okay, plus or minus respiratory distress, you will check for the distress, and lungs, coarse crepitations or rhonchi. So usually if there is no lobectomy, the child can have coarse crepitations in the bronchiectatic lobe. So what are the things you see? Failure to thrive, look for clubbing, and for the presence of CVL portacath or at least scars, that if it was performed before. Then lateral thoracotomy scar, any respiratory distress, coarse crepitations and rhonchi. Next, in differential diagnosis, Dr. Muzna, you are here.
Yes, Dr. Noor.
Yeah, I want to tell
I
you
completed the phone call.
Differential diagnosis, you put this severe lung infections like pertussis, measles first. How common it is in bronchiectasis when you compare to these reasons like cystic fibrosis, Carter-Jenner syndrome, and CCAM?
Infections are always more than congenital causes,
yeah,
right?
But how common is the measles presenting with bronchiectasis, I mean? So which one you will put the top?
I would just put like bronchiectasis, congenital lobar emphysema. Then okay, you have put this as a causes of bronchiectasis. I put it separately: bronchiectasis, congenital lobar emphysema, lobar sequestration, and CCAM. I told like that. I did not put them as a cause of bronchiectasis.
Yeah, but I am telling you, it don't put severe lung infections presenting with bronchiectasis like pertussis and measles they are not as common as these conditions, CF and lobar. This is what I'm telling. So put your top differential, the most common one, always.
Okay.
Any comments for this? What do you say? We will put infections first here, or cystic fibrosis, ciliary dyskinesia, and CCAM first?
No, this ciliary dyskinesia, lobar sequestration, CCAM, this will come first. Infectious will come in the bottom.
Yeah, this is what I want to tell her. Put these things first in these patients. Like so the differential diagnosis is divided into idiopathic, congenital, acquired, and immunodeficiency. If we don't want to tell everything in every, I think congenital, remember everything. For these things you can select 2-3 things and just tell, because so much long differential diagnosis we don't have time to tell in the exam. It's just 3 minutes. So mainly this child is 5 years old already. Lobectomy is done, maybe due to this congenital causes, or can be due to these infections, but less likely. Okay, and also can be due to immunodeficiency as well. So congenital is cystic fibrosis, primary ciliary dyskinesia or Carter-Jenner syndrome, lobar sequestration, congenital adenomatoid malformation, congenital emphysema. These 5 things you can remember. Okay, almost everything is starting with C. Okay, cystic fibrosis, ciliary dyskinesia, CCAM, and congenital emphysema. If you remember 4C or 5C, yes.
Dr. Noor, which came in the exam, that was age was 1 year, not 5 years.
For which?
This came in the exam, the Sodia exam, Lobeck. So that is age they have written 1 year. So if it is 1 year, then definitely you will have to think of these all things which you are telling.
If it is 1 year, then congenital malformation or CCAM
Congenital
will come on the
malformation.
first place.
Also, this bronchiolitis obliterans, you can think of that. That is also related with the adenovirus. You can think of pertussis. You can think of this congenital lobar emphysema. All these things. And if it is more age, then you will have to think of maybe cystic fibrosis, primary ciliary dyskinesia, or maybe associated with any other infections like TB or measles, other infections.
Okay. And also when you are telling infections, use the word severe, because the mild infections will not go to this extent. So use the word severe. Next, acquired, it can be airway obstruction. Yes, 5 years old child, you can put this foreign body aspiration. Then mediastinal lymph node, that is tuberculosis and can be a lymphoma. Recurrent aspiration and pneumonitis, that is in tracheoesophageal fistula. Again, in this child you can put it, but I don't think they will keep for such a long time. They have to do the repair as soon as possible, this H-type tracheoesophageal fistula, because of the recurrent aspiration and pneumonitis. So depending upon the age of the child, you can prioritize your differential diagnosis, right? So recurrent aspiration, pneumonitis. Then when you're telling lung infections, say severe lung infections like pertussis, measles, and adenovirus, bronchiolitis obliterans. Next, immunodeficiency syndromes plus recurrent chest infections, primary immunodeficiency, X-linked A-gamma globulinemia, IgA deficiency, complement deficiency, hyper IgE syndrome, secondary immunodeficiency like HIV. Okay, so if there is no time, you can just mention this heading with immunodeficiency syndrome with recurrent respiratory infections, and just 1 or 2 previous severe lung infections. Like, I think this is more important, adenovirus bronchiolitis obliterans. Then you can.
This is very, very much important.
Yeah, when you compare to these 3, in these 3, this is more important. So highlight this. This, because the repair will be done as soon as possible, you can put it in the down, but don't forget cystic fibrosis in any age. Cystic fibrosis and ciliary dyskinesia, don't forget in any age. So, okay, the baby like 1 year, you can consider this CCAM and congenital emphysema, lobar sequestration, everything.
Dr. Fatima, just now I joined. This is your studying what?
Yeah, I am studying for bronchiectasis. I don't know why this mic struggle. So in order to complete my examination, tell peak expiratory flow rate and spirometry is very important. Don't forget in this station to tell. I think Dr. Sridevi also did not tell. I don't know about Muzna. I don't remember whether she told spirometry or not.
Oh, even I didn't see.
Yeah, you both did not tell. Again, depending upon the age of the child, if more than 5 years, say PEFR, no problem. Okay. So peak expiratory flow rate and spirometry. Then sputum inspection. Okay, so you told that you want to spend for see the sputum and for sputum culture. Then temperature chart, SpO2 chart, plot on growth chart, then CVS examination. In order to complete my examination, always in this case, don't forget CVS examination also. Because you should rule out pulmonary hypertension, cor pulmonale, dextrocardia in cardiagenesis syndrome. But when examining, both of you checked for the dextrocardia by locating the apex beat. Okay, just 1 minute.